Welcome everyone to the summer lecture series this year. Today, to everyone in the public and to our RIPBG team, we're going to start with our featured speaker, Lieutenant Michael Wilinski. He's a flight surgeon for the Helicopter Maritime Strike Squadron 48 Medical Corps, U.S. Navy. He's actually a former RIPG intern, and he'll be presenting a brief review of ankle sports trauma, similar to military recruits. So without further ado, Dr. Wilinski, would you like to share your screen?
Absolutely. 1 second here. Here we go. All right. All right, are we on the start page right now? Brief review of sports trauma, ankle injuries.
Yes.
Some? Okay. All right, good afternoon, good evening to all of those that are joining us on the talk today. My name is Lieutenant Michael Wilinski. I am a physician in the United States Navy, currently with HSM 48 down here in Mayport, Florida. I'll be covering a brief review in sports trauma ankle injuries, similar to those seen in military recruits. As I mentioned, lieutenant in the United States Navy. Last year, I was a general surgery intern at Walter Reed National Military Medical Center. Prior to that, I was a osteopathic medical student at the Lake Erie College of Osteopathic Medicine in Bradenton, Florida, having graduated in 2018. Between the years of 2015 and 2018, I had the great privilege of working for Dr. Lopez in the Rugby Research and Injury Prevention Group, working my way from intern all the way up until National Study Coordinator. Moving forward with disclosures, again, I have no conflicts of interest to disclose, and I have to disclose as part of the military that all topics, opinions, and discussions rendered here today are my own, and in no way represent those of the U.S. Navy, Department of Defense, or the United States government. So to get straight away into it, what I had kind of thought of as you know, being given this topic, you know, we want to kind of underlie and highlight the importance of understanding these injuries. Lower extremity injuries, they kind of cut across all high physical activity groups. So in recruits, military recruits that are being forced into combat, basic combat training, or even rugby players that also are taking part in a very physically demanding game, one that requires you run the ball. I found these two pieces of data that really helped us out. The first one being in one basic combat training study at Fort Jackson, South Carolina, in basic combat training, 84 to 80% of all overuse injuries in men and women involve the lower extremity. So that could include shin splints, that could include stress fractures specifically. Furthermore, the lower extremity being the most common site of injury, from 41 to 55% in all rugby injuries sustained in the lower extremity. So looking amongst the data, it shows that lower extremity injuries across both military recruits and rugby players have a significant impact on our ability to train moving forward and our ability to perform moving forward. So we're going to cover a couple different injuries today, and so we get an idea of what they are, a couple of caveats about them, and what some treatment modalities may be. The first is turf toe. Basic definition of turf toe is the sprain of the first metatarsal phalangeal joint as a result of excessive hyperextension. The most common Mechanism of injury is jamming of the toe or repetitive push-offs when performing runs or jumps. The symptoms are pain and swelling of the great toe area around the metatarsophalangeal joint. Diagnostics, there has been a correlate that turf toe is shown to occur with those individuals that are playing on artificial surfaces. Treatment is very conservative. Typically, it's rest, ice, compression, and elevation. More serious cases can be treated with orthotic use using a turf toe plate within the shoe, an insert within the shoe. Less than 2% need any sort of surgical intervention. The concern there is that there's major plantar complex tears and possible sesamoid bone fractures within the plantar fasciitis. Next, and perhaps most commonly, is the medial tibial stress syndrome, better known as the shin splints. Most commonly in military populations, mid-shaft or diaphyseal stress fractures are encountered throughout the different populations of men and women. The region of involvement, however, has the poorest outcome to training military individuals. Typically, it impedes them from continuing training due to the amount of rest that's required to overcome the pain that's associated with it. The pain can be described as a diffuse lateral pain across the posterior medial tibial border, a chronic presentation, most likely in amateur female athletes. Females, again, have a preponderance. Females in the military recruiting stage also have a preponderance of this issue, especially with increased hip rotation and orthotic uses. Most clinically significant treatment, as I had mentioned, is rest, and then orthotics and shock absorbing insoles can help to prevent. But again, it's a combination of the biomechanics as well as the anatomical structure that is currently within that individual. So ankle sprains, we could probably spend its own entire topic on. The real question that I wanted to bring up is if it's necessary to bring surgical intervention into ankle sprains. And what the data shows at this point in time is that it's rarely needed for any sort of lateral ankle sprains. Conservative treatment does have good results for all competitive athletes, and the complication rate is much lower. However, it is a different story if you're thinking about the medial aspect of the ankle, the deltoid, especially the deep deltoid. If that's torn, sometimes they go towards surgery on that. Also, if you start thinking about syndesmosis or syndesmotic areas up in the higher ankle, they're starting to come up with new procedures, which I will get into a little bit later on. Surgery, unfortunately, for the recurrent instability typically spells the end of the career for the athlete, and the same for any military recruits. The next injury that we'll cover is the fifth metatarsal fracture, otherwise known as the Jones fracture. It's a metaphyseal diaphyseal junction fracture where there's a poor blood supply. Typically, the Jones fracture is taken care of with conservative care, 6 to 8 weeks plus or minus a cast on non-weight bearing. It allows for proper healing. There are instances, however, where there isn't good healing with the casting and the conservative treatment. Why does this fracture occur? There can be lateral overload, overuse, and a lack of blood supply. There's increased motion of the fifth metatarsal with rigid base anchored by the ligament and the tendon. Distal accommodates uneven surfaces. There are instances where there's something called dancer's foot, where you have a avulsion also of the peroneus brevis that attaches to that little piece that juts out from the fifth metatarsal. However, that's just where that pulls off and not the whole shaft breaks. In considering surgical treatment for the Jones fracture, you need to consider foot alignment because it depends on how you want to put the screws into place. Pes cavus or high arch is, if it's common, you don't have to correct it initially. Metatarsus adductus or a supinated forefoot can often limit the screw size. The bigger the screw size, the more likely it's going to hold. Going back to pes cavus very quickly, the fixed plantar flexion of the foot in pes cavus results in pain, possible fractures, tripping, loss of sensation, and dragging one's affected foot or feet. Continuing on with the fifth metatarsal fractures, the most common surgical treatment is the intramedullary screw. Produces a predictable rate of healing earlier and allows for earlier and more aggressive rehabilitation and a more rapid return to the sport. Return to sport prior to the radiographic union is a risk factor for re-injury, and then there's no comparative studies in the literature. Other notes in athletes, or if pieces of bone are separated by more than 2 millimeters, surgery may be considered. Otherwise, surgery is recommended if that healing does not occur after 12 weeks of casting. So what type of hardware would be used? Solid, no advantage shown over a 4.5 millimeter screw. Bigger, not necessarily better, but you want the biggest screw that fits the canal, according to Porter et al. There is a slight risk of bending due to the natural lie of that bone, especially with the amount of forces that are on it. That's the image 6 weeks post-op. Next is medial malleolus fractures. Cause typically the impingement of the talus in the medial ankle during dorsiflexion and tibial rotation. High shear forces. Typically treatment can be conservative, activity modification, casting or brace, or surgery. So internal fixation with screws perpendicular to fracture line plus an anti-glide plate and a complete fracture line along the complete fracture line. So this is a case of a 26-year-old at the Olympic Development Academy. As you can see, there is a clear fracture line here. This individual, after receiving a internal fixation with screws and plate, returned to play in approximately 6 weeks. Medial malleolus fracture, the pearls of this. Again, you're going to have some non-specific ankle pain. Fracture typically starts anteromedial and goes vertically. A high rate of non-union with only 2 screws involved. Therefore, a plate is needed to take off any anterior ankle spurs off the talus as may be the cause of the pain. There was a 25-year-old who failed 3 ORIFs and did not heal until lateralizing calcaneal osteotomy, as had cavus foot, which is a risk factor. So in the way that the foot was, lied, did not allow for proper healing, and therefore bone had to be removed in order to allow for proper healing and pain subsiding. Next is navicular stress fractures. The central third of the navicular can undergo some high compressive forces, and that bone specifically has a poor blood supply. The old literature showed that this occurred 2.4%, but new is 14 to 35%. It's often a delayed diagnosis. An exam shows pain over the dorsal bone or undescribable ankle pain. In diagnosis is an insidious onset. There's vague symptoms. Typically, the proper setting is a running, jumping athlete. Symptoms tend to improve with rest, but recur after activity resumes. Again, the exam is unimpressive. A single leg hop can sometimes be used to cajole the symptoms to occur again, and x-rays are typically negative. Therefore, what do we do to try to find out what the problem is? Well, x-rays are negative approximately 67% of the time, and greater than 80% of them are incomplete, showing us what kind of findings we need. The bone scan is 100%. It can find it, but it's rarely used. MRIs have a high signal with 95% sensitivity, but the gold standard is the CT scan, which shows fracture pattern, completeness, displacement, degree of sclerosis, and intermedullary cysts. You can see in this photo right here, this is a 3-month post-op for a navicular injury with a screw in place. Next is the subtalar lateral dislocation. It's the less common type of dislocation. The calcaneus is displaced laterally to the talus. The talar head lies medially and the foot appears pronated. The navicular lies lateral to the talar neck. May be complicated by interposed posterior tibial tendon or sometimes the flexor digitorum longus. A subtalar medial dislocation, and this is the anatomy of this injury, it's more common. It's 85% of all cases. The foot and calcaneus are displaced medially. The head of the talus is prominent dorsolaterally. The navicular lies medial and sometimes dorsal to the talar head and neck. This is also known as basketball foot. Here is a reduction of a medial dislocation. You can see there's some traction going on there. With slight eversion in order to bring the bones back in line. When our medial dislocations indicated to be worked on operatively, it's only about 10% that require an open reduction. Typically, when the capsule of the talonavicular joint and the extensor digitorum brevis blocks reduction, or in some cases, the talar head may buttonhole through the EDB. Typically, there's a longitudinal anteromedial incision over the head and neck of the talus, and manipulation in order to release, have a release of the interposed tissues. The joint is stable post-reduction. There's no need for internal fixation with any screws. And post-reduction, there's a short leg cast for approximately 3 to 4 weeks. There's some concerning confounding findings, especially when you deal with dislocations. Dislocations of the distal articulations of the talus at both the talocalcaneal and talonavicular joints. So it's really key right there to always have good imaging to figure out which direction you would need to potentially reduce that dislocation. You need to think about osteochondral lesions. Osteochondral lesions are typically the torn cartilage, especially in the calcaneal joint, and above that where the talus meets the tibia. Other concerns are the syndesmotic avulsion fractures and the syndesmotic issues. That's typically described as the high ankle sprains, where the anterior inferior talofibular ligament is affected. Also, the interosseous, there's an interosseous layer that's between the fibula and the tibia that can also be strained in that instance. A new surgical technique was developed in the last few years called the tightrope fixation, which is slowly being used for these syndesmotic issues. It was made popular by the case of Tua Tagovailoa, where essentially a canal is drilled through both the fibula and the tibia, and a high tension suture wire is placed through using buttons on each end to bring both of those bones together and provide stability to the ankle. Finally, the Massonov fractures, a spiral fracture of the proximal third of the fibula associated with a tear of the distal tibiofibular syndesmosis and the interosseous membrane associated with the fracture of the medial malleolus and or the rupture of the deep deltoid ligament of the ankle. Return to play. Return is dependent truly on the amount of trauma at the initial injury. A player in the case was cleared to return to activity 7 weeks post-injury. That leads to the discussion question that I have: is surgical repair truly worth it? In the elite athlete, the data says yes. Hopping, counter jump movements, high-speed plantar flexion torque greater than 240 degrees per second show improvement in re-rupture rates lowered. For the weekend athlete, however, the data is not as clear. Maybe, we think, but soft tissue complication rates may outweigh small functional gains achieved at high torque if an early weight-bearing and rehab program is employed. For further reading on these issues, go ahead and look up The Contemporary Controversies in Foot and Ankle Surgery, an issue of Clinical and Podiatric Medicine and Surgery, volume 29-3, Emil Blitz, DPM. That is all from me. If there are any questions out there, that is my contact information if you'd like to go ahead and reach out to me. I thank you for the opportunity to give this talk and to speak with you today. We'll have a little bit of a discussion after this on any of the specific injuries, or if there are any questions. And I'll go ahead and turn this over to Sam.
Yeah, thank you so much, Dr. Wilinski. Any questions?
I have a question. Of the lower extremity injuries that you discussed, are there certain injuries that are more frequent, like specifically amongst military recruits in comparison to athletes?
So the big one was stress fractures. Between stress fractures and the shin splints, when say for example, like 17, 18 years old, may have been an athlete in high school, may not have been an athlete in high school, are now given a pair of steel toe boots and have to ruck march every single day. In addition to that, you're carrying 50 to 100 pounds on your back doing that kind of combat fitness training. So again, it's the impact on your legs. There's a ton of impact on the legs each and every day. And again, shin splints, when they have to run, come into play. Uneven terrain and the footwear that they're using really kind of sets up against them. If you look in my lecture exactly, I included the book written by the Borden Institute from the Walter Reed Army Medical Center. It's Dr. Bernard de Koning, Recruit Medicine. It has the exact studies. It mentions the exact studies, and it's easily searchable online without any sort of government access.
Excellent, thank you.
You're welcome.
Any other questions? Well, with that,
Sorry, I had a quick question. I just wanted to ask, like, how is the naval flight surgery training different from regular general surgery training, or do you go into specialties of podiatry, or is it?
So the Navy has a little bit different way of completing completing your training. So in the Army, I'll just kind of go through what the branches do. The Army and Air Force are, they allow you to go ahead and kind of figure out what specialty you want to do, and you complete that specialty through its training. The Navy still holds on to a bit of an antiquated system where they have you complete your internship year. So I completed mine in general surgery, and then a vast majority of those interns have to go out into the fleet in some capacity because there's less spots for residency than there are for internship. So the point is they need doctors out in the field, and usually those doctors need to be general practitioners and understand a whole breadth of medicine versus being able to take care of one specific branch of medicine. So they don't want to be sending like an orthopedic surgeon out to take care of a flight wing that might have issues with, say, COVID, or may have issues with upper respiratory infections or headaches and alcoholism and a lot of other psych issues that you may not think of. There are instances where there are some people that get to go through. Podiatry specifically is its own school. It's different from the schools of medicine being osteopathic and allopathic. And there is a route to becoming a podiatrist in the Navy, as well as the other armed forces. So yeah, it's a little different, and it kind of pauses you on what you want to do in training. But again, if you're gung-ho on career, or if you really want an experience different from what you see your colleagues having many years in one hospital, kind of takes, I've heard stories of burnout, and this is kind of like I'm putting a pause on my training in order to experience what the Navy is going to be able to give to me, and then afterward go into my training knowing full well what difference I've made to the service. So avoiding burnout is helpful, and being able to do something in medicine that not only helps the squadron but kind of helps the mission forward.
Right.
Does that
I just wanted to ask, what are you going to go back into specialize in? I mean, do you have any?
I haven't figured out what I want to do when I grow up yet. So general surgery last year was probably one of the toughest years I've ever had. And I think Dr. Lopez can attest to a general surgery intern year. That being said, thinking at this point, I'm kind of between a couple things. Emergency medicine is high up there. Family medicine, for the sake of its flexibility and allowing me to jump between different commands and communities in the Navy. And that is a route to sports medicine in the Navy. And then ophthalmology, because it would allow me to be a surgeon, but not have the hours of a general surgeon. So we'll see. I haven't really decided yet. And I've got about 2 years to figure that out.
I see. Thank you. Thank you so much.
You're very welcome.
I think, Michael, you hit it on there. The hours of general surgery are very taxing, if that's the best, on how you're going to manage your time, is how you want to use it for your future practice. I think what the Navy offers you, or the military branches in general, offers you that larger spectrum of exposure as compared to you going directly into a focused area, or then there specialty afterwards. I think everyone knows now that medicine and what to your career. And again, it could be 24/7, or it could be, you can really try to manage it. And I think Michael put it perfectly in describing, what family practice with the diversity that's offered with post or let me rephrase it. Multiple post-fellowship opportunities, because I do think that did family practice, then did sports fellowship, and then did pediatric sports fellowship after that. So it was very unique in her doing almost 2 fellowships. Now again, I don't know if that's with everyone program. You may want to do as a in and have the ability to be family practice, or have the diversity to expose yourself to the community. And I think that's a big push for many of the major bases that they offer, right, Michael? Am I correct?
Yes.
They want that?
They're asking for dual designators, people that have subspecialties already, but they also want you to be able to reach back to your older training and kind of cross cover on each and everything. I know that the Navy really likes people who are a flight surgeon, are board certified, and potentially have a third designator in order to kind of push them up into command level medicine to make decisions on policy and kind of where the Navy's going with all their medical decision making.
Well, thank you again, Michael. It was a great talk, and it's always great to see you. I'm very happy to see you being successful in your career moving forward.
Absolutely. Thank you.
Yeah, thank you, Dr. Wilinski, for that presentation.